Dear students, now as a continuation of the corneal basics and corneal examination techniques, now we come to an interesting chapter on corneal instrumentation. There are a lot of instrumentation which is used to study the cornea because we already touched upon these things. If you remember, corneal thickness, how do you measure corneal thickness? How do you measure the corneal radius of curvature? How will you map the cornea? These points are very essential, and so we'll go ahead in this PPT. We'll try to see some investigation techniques in the cornea which are very useful for you to understand and to answer in the examination. Important instrument in cornea is keratometry. Keratometry measures the radius of curvature. The radius of curvature. Radius of curvature. How do you measure it? The keratometer is a standalone instrument. It has a chin rest and a forehead rest. Patient sits here and keeps his chin and forehead here. And once he sits here, you focus this keratometry into the patient's cornea. As you are focusing, these mires will get focused. When these mires are getting focused, you will have to approximate the plus and the minus and minus of the neighboring mires. Once you approximate like this, when you see only one minus and one plus only, then the approximation is perfect. Once you have done from the dial, there is a dial here. No? Can you see this dial? There is a dial here and there is a dial here. There are two dials. So you can read from them. One is K horizontal, another is K vertical. So cornea is an aspheric surface. So the corneal curvature, if you notice the corneal curvature, it will be in the vertical meridian 1. And in the horizontal meridian, it will be another. So the vertical meridian and the horizontal meridian of cornea are different. So their radius of curvature will be a bit different. We call them as K horizontal, KH, K horizontal. We call it like K horizontal. We'll put a K and as a subscript, we'll put H. So KH is horizontal. Likewise, KB vertical. Okay. So usually 7.4. Usually expect somewhere around 7.4. This is the normal usual reading, but not necessarily so. Each of the patients might have their own values. So anytime when you are doing an IOL power calculation, you need a keratometry. K reading is a part of the IOL power calculation formula. Similarly, when you are putting contact lenses in a person, then you need the K reading, because K reading gives the size, dimension of the contact lens which will suit the particular person. Whenever you are thinking of astigmatism in a person, K reading is very important. Okay. The next interesting instrument is pachymetry. Pachymetry measures the thickness. Remember, thickness. If you remember, we discussed that the central cornea will be somewhere around 540 microns. 540 microns. Okay, that will be the central cornea. And the peripheral cornea will be somewhere around 1 millimeter. It would have gone to 1000 microns. Rather, 1 millimeter will be the nearer to the limbus. If you measure, usually the corneal thickness will be 1 millimeter. But when you measure the central cornea, then it will be somewhere around 540 microns. 1 micron is 1 in 1000th of a millimeter. The measurement is done in a lot of conditions. Like if you want to study the corneal thickness in a person who is going for LASIK surgery, then a pachymetry needs to be done. Secondly, when we are dealing with intraocular pressure also, if we take applanation tonometry, after an applanation tonometry, we have to do a central corneal thickness and use the central corneal thickness to modify the applanation tonometry value. The applanation tonometry value will be different in a thin cornea and a thick cornea. So if you take the thickness of the cornea, it should be a correcting factor for the corrected IOP. So the intraocular pressure measurement needs the pachymetry, and LASIK procedures need pachymetry. Placido's disc. This Placido's disc is a traditional disc which is used to be shown on the cornea. If I make you sit in front of me and I shine this Placido's disc on your cornea, then the cornea will show a reflection of that Placido's disc. If your cornea is regular, then the reflection will also be regular. If your cornea is like steep, the reflection will be distorted steeply. If your cornea is conical, then it will be reflected like a conical projection. Can you see keratoconus? We will discuss it separately, but now you understand that in keratoconus, the placidus disc will nicely show a conical cornea. So this is one another examination technique of the cornea. Topography, like a atlas map, a geography is studied by a map, no, a Google map. Like that, the cornea also can be mapped. We can map every point of the cornea. The cornea is so very precious. So each point in the cornea, I can see how much thick it is, what its radius or curvature it is. So when I map that, I can put it as a colored map. This color is just a false code. This color is not there in the cornea. It is just a code for us to see the map and understand, like the red color. Red color will show very steep areas, Blue color will show very flat areas. If I see blue color, it is very flat. If I see green, it is in between. Green and yellow, it is in between. So likewise, I can measure the corneal curvature and the corneal thickness of each point and map it, because this becomes very essential if I am going to do a LASIK procedure or a refractive surgery in a patient. The instruments used, one is called OPSCAN and the another is called Pentacam. So OPSCAN and Pentacam are two interesting equipments. OPSCAN and Pentacam are two interesting equipments which are used for corneal topography. Specular microscopy, we already even touched upon this. We said slit lamp examination also, there is one technique called specular illumination, but that is crude. Now we have a pakka instrument itself for that. This instrument is called a specular microscope. This specular microscope can nicely record my endothelium. We'll revise the certain points in endothelium which we touched upon in the first PPT. The endothelium is very precious. It will never regrow. So a defect happens, what will happen? If there is a defect, then the neighboring endothelium will grow up and cover up this defect. See this neighboring endothelium. See this neighboring endothelium has grown up to cover this defect. This is called polymegathism, where the neighboring endothelium grows up to cover an endothelial defect. But certain times the defects will become so very much, then you cannot, how much of polymegathism can happen? There is a limitation for that. No, if that is going to happen, then we call it as cornea guttata, corneal wastage, corneal endothelial wastage, which occurs. Especially when we discuss cataract, we'll discuss about a lens called ACIOL. We'll discuss a lens called ACIOL. This ACIOL, they will tell you, is very dangerous because it rubs on the corneal endothelium and destroys the corneal endothelium. So that you remember here. When you are discussing corneal endothelium, remember here. Another is the count. The normal count is somewhere around 2500 to 3000. 2500 to 3000 is the normal count of the endothelium. This at least is minimum. If it is below that, you will then have corneal endothelial decompensation, which will lead to a kind of corneal disease called bullous keratopathy. We'll discuss that when we discuss complicated cataract surgery. Bullous keratopathy. This is 2500. Okay, this is 2500. Okay. So thank you. So now we have discussed certain instrumentation techniques which are used in cornea. I'll want you to just keep in your memory that there is a keratometer which can record the radius of curvature, a pachymeter which can record the thickness of the cornea, a corneal topography which can measure the map the layers of the cornea. You can have a specular microscope which can look at the endothelial count of the cornea. So thanks once again. We'll again meet in the next portion of cornea.